Hello, welcome to another podcast from Diaries.UK. This is Dr.MOSES Wesley. Today we have an exciting and a very impressive guest who used to be and always my mentor, even now in the field of medicine. And today we are going to discuss cardiology, and for that we have an eminent person in the field. Let us welcome to our show Dr. Haynes Raja. And few words about him. He's a highly skilled cardiologist. He's specializing in cardiac electrophysiology, and he has done both his undergrads and postgrads from Rajamuthiya Medical College, and he has done his DM cardiology from CMC Vellore. And right now he's pursuing his postdoctoral fellowship in electrophysiology. And also, many of you may know already, like he is the winner of Dr. George Sherian Medal for best student in DM cardiology at CMC Vellore, and he also won the first prize for the clinical pathological case presentation during his undergrads training, and another first prize in postgrads thyroid quiz at JIPMER. He's an enthusiastic teacher, a marvelous physician. He enjoys traveling, and he has a creative side, indulging in piano playing, photography, and badminton. We know each other for nearly close to 10 years now. And let us welcome our special guest, Dr. Haynes Raja. We welcome you, sir. It's a pleasure to have you here.
Hi, Moses. It's a pleasure meeting you again through this podcast. So I'm sure this MRCP is a very interesting thing, and we enjoy learning and teaching. So it's a great thing, and it's very good to do it. So like you feel good, you feel confident, you feel confident to face the patients, right? So I'm sure we enjoy, right?
Absolutely. I can still remember every part of my PACES journey. Let it be whatever ups or downs, this MRCP journey has taught us a lot, and we were together along with other couple of our colleagues. It's exciting to know that.
Exactly.
And it's the first day in the cardiology today. All the cardiology podcasts will be taken over by Dr. Haynes Raja, and he will be just like he is going to brainstorm us with a lot of good stuff in cardiology and a lot of things which we need to know as a physician to clear the MRCP PACES examination. All right, the very first question for Dr. Haynes Raja is like, doctor, what made you to do MRCP PACES? What just motivated you to do that?
So as we know, like I'm from a developing country, that is India, and I love medicine very much, and from my undergrad days, I love to read Harrison's, which is considered the Bible of medicine, and love reading, love seeing patients, love going to the bedside and seeing patients. So I enjoy the process of learning and teaching the students who comes under our purview. So I enjoy doing that. Meanwhile, one of my teacher, Dr. Perumal, so he's an eminent physician, and he told me that it's good, you should do MRCP, and it improves your value. It has a lot of good things when you are thinking about future prospects, like that he told. So that moment I thought that okay, I should give this exam, and I should find how it is, how things are, how my skills can be improved, like that. So I'm sure MRCP is one forum where I can demonstrate my knowledge and my competency in internal medicine. I'm sure everyone is aware that it is internationally recognized, and the patient care, what I am providing, will be streamlined and it will be made better. That's my idea before going into that. And of course, my patients who are coming to see me also feel that they are safe, they are in safe hands. So traveling through PACES, I'm sure Dr. Moses will agree with that. I'm sure traveling through the PACES, I will say my communication became better day by day as I went through the skill set, the exam, the training process. I became very happy. I became a better person. I became a better talker and better translator of what things are, what is important, and about their diseases, what they are undergoing, what are the pain they are undergoing, to comfort them. So much things improved over a period of time. And of course, my skill set also sharpened, what to look, what not to look, what not to wear, not to waste time. So such kind of things, even my day-to-day practice, I will say, it made immense improvement. So I'm sure like MRCP, I'm sure going through MRCP will definitely help. And of course, I don't have any plans to move abroad. At the same time, if I want to upscale my career, like say for example, I have to go abroad, work further, and I want to get into a system and learn more from them. Of course, they will be confident to hire me, and they'll be happy to take me, that I have a international qualification and international my skills are on par with an international candidate. So that way, I'm sure it will be very helpful. So these are the ideas what made me to do MRCP paces. Yeah.
Fantastic. That's very elaborative, and we learned a lot of stuff. Like, it's absolutely true. It holds a lot of value. And one point which you made is excellent, that it changes the way we communicate with the patient. Typically, we don't inculcate such system in the communication in day-to-day life in subcontinent area, but MRCP indeed changes our communication skills, not just with the patients. For me, even with the people around me, even with the friends and the family, the way I communicate has drastically changed ever since I started preparing for the basis examination. That's absolute truth.
Exactly. So the important thing what I would like to tell is the meaning of doctor per se is to teach. Of course, Dr. Moses will also agree. So the meaning of the doctor is to teach. So of course we are expected to translate what we understand to the patients for improving their life, and making them happy, live a normal life. So whatever the disease may be, it is our it's our role to translate what we know, help them become a better person, become happy and joyful. Finally, the quality of life matters, not the disease matters. So I'm sure Moses will agree with that.
Absolutely. Not just me, everyone will agree with that. Finally, the quality of life matters a lot. Absolutely, it matters a lot. And one question for you is like, can you tell us about your PACES preparation journey? Of course, all of us have different ways, and we could have prepared in different ways. Like you, as a busy clinician on site, like, with post graduation and all the things going on. And I know obviously CMC Vellore is one of the very busiest centers in the world. And in that, how were you able to manage your time and prepare for your MRCP PACES UK examination? And what are the things you have done for that?
Oh, my PACES exam happened in a hurry. I have to admit that. Uh, just after my DM cardiology exam, I did a doctorate of medicine in DM cardiology, that is in CMC Velo. And 1 month after that, there was a PACES session, PACES exam session coming in India. And I was not in the mood to go outside and do this. So I wanted to get it done in India only. At the same time, sure, the cost involved is significant. So without having a prior idea of what to do, how to do, I'm sure I was very puzzled. Should I take it in 1 month time? It is going to come. Should I take it like that? I had in my back of my mind. So when I discussed this, so this was taken, of course, as a family. We just sat together, discussed. My parents and my wife. So we discussed what is this? This is the exam. This is how it is going to be. And of course, immediately after my DM exams, life was terrible. Of course, the patient load is so much, and we have to give our life to the CMC. That's how it happens. So after having a discussion, one good thing which happened to me was one of my friends, a close friend whom I used to sit and study with, was also appearing for PACES. So he has applied for PACES. So that's the important factor why I took that slot. Otherwise, I'm sure I would have waited for at least 6 months to 1 year before going for that exam. So Dr. Sairam is the one who was about to give the PACES exam. So then he told me he has got a lot of information on how it has been done, and how things will happen, how the exams will happen, everything. So he clarified me a lot of things, and I was happy to join together with him to study. So the important thing is, of course, I want to first thank God, parents, and my family, and my best friend, who is Dr. Jayakumar. So all of these people mattered in my life. But the important thing, important person, most important, I will say, is Dr. Sairam, because with whom only I studied. I took my PACES journey day by day. So I had I was working in CMC, and at the same time I cannot take leave as I like, because I'm a junior faculty and I have a lot of responsibilities. The unit has to cover the responsibilities in my absence. So they asked them for 10 days leave. So that's what happened just before the exams. At the same time, I and my friend used to visit wards every day. So every day we used to go see at least 2 cases. So by like 6 a.m. or 7 a.m. we visit the wards and look for cases. So we go to one day to a gastro ward, one day to cardiology ward, or one day to a see a neurology ward. Like that, we visit various wards and we get cases. Of course, the doctors, some of our friends will be in that departments. We'll ask them just at the level of undergraduate, any cases, please tell us. Don't tell the diagnosis. Tell us what cases are. So that's how we get to know the cases. We just visit. I'm a cardiologist. My friend is Dr. Sayram is a gastro. So both of us had a good abdomen and CVS cases. So apart from that, RS, respiratory system, and your CNS, our friends helped in identifying the cases. They will not tell the diagnosis, we'll go. So I'll examine sequence, and then Dr. Sairam will examine the sequence. Then we'll discuss what is the diagnosis, what is the probable diagnosis. Then we'll go to the investigations, look at what is happening, what has happened to the patient, and we'll verify our diagnosis, and we'll discuss the pitfalls, like what I did wrong, what he did wrong. That's how it happened. So it happened for almost a month. Like every day we used to go either in the morning or in the evening after our session, like our routine work ends. That's how we practiced every day. And I'm sure that made a tremendous difference. And so last 10 days I took leave, and out of that 4 days was a workshop which was held in Chennai for the PACES. And so the mock drill, of course, mock drill also helped me building confidence. So then we had like small, like we had to rush to them because I did a kind of crash study for PACES. I'm sure no, I won't encourage anyone to do this. But it happened that 4 days mock drill was there, and then after that, next day was a Sunday, and the next day was my examination. So 4 days mock drill, then Sunday, the next day was my PACES exam, which was held in Chennai, India. So that time I was, I didn't feel that I'm going for an exam. The reason is already the demonstration is over, and the demo tests, the mock tests are over. I have been through that process. I understood what is happening, and so. And of course, there are seniors, of course, my friends, Dr. Moses, Dr. Vijay Kumar, Dr. Bharadwaj, all these people. So they told me, this is what is expected. Don't tell the diagnosis just like that. Just think about differential diagnosis. They are not expecting diagnosis. Diagnosis is not given any marks in exam. You just have to have the differential diagnosis and try to find out a diagnosis out of it if it is possible for you. So that's how you have to approach the exam. It's not like you have to hit hard. You should tell that this is the diagnosis, then only you're going to get the mark. Nothing like that. So that way was clarified. I'm mentally prepared. So I will say learn from others' mistakes, not from your own mistakes, because life will not give opportunities for you to make mistakes again and again. So that's how my mind was prepared, and I just went through the exam just like that. And the 2 hours went just like that. I didn't realize how the 2 hours. At that time it was only 5 stations, and we had 10. Of course, the same. Used to be. It went just like that. After coming out, I realized I have done a reasonable job in the exam, and so somehow by God's grace, I turned out well. So what I recognize is important. I would like to highlight. I'm sure Dr. Moses will agree with this. The way of preparation I went through. Any comments, Dr. Moses?
Absolutely. That's true. That's like, I thinking back, like everyone had a different level of preparation, but I always wondered like how people who are really, really busy with a real busy patient load still managed to go ahead and crack the exam. That's wonderful. And it's such a pleasure to have you here, and such a pleasure to know all the stuff. All right.
Yeah.
Okay.
Thanks. So what I would like to tell about what I recognize as important after finishing that exam, after finishing that, you feel like the tense situation. You have paid so much money, and you are going for an exam, and it is going to happen like not very, if you miss an opportunity, again, it may happen in 3 to 6 months. Again, you will have to get the slot. You may not get the slot as well, and you may not get a study partner in the next time. So a lot of things, mental pressure was more, I will say. But what I recognized as important is, number one, the clinical exposure during your early years of training. Maybe it be undergraduate training or a postgraduate training. So by then, I was very confident with two systems. Cardiology, whatever cases you keep, I can crack it. And respiratory system, whatever cases you keep, I can crack it. So such kind of mindset was there in the back of my mind. So I know that my strengths were the cardiovascular system and respiratory system, and weak areas were central nervous system and abdomen. So I had to work more on those. So I will ask my friend to give me more cases. So before he examines, I will tell that I will examine first. I will have to tell the diagnosis, or I will tell you these are the findings present. Then you examine like that. So I took those steps, like recognizing my strengths and weaknesses. That is very important. So focus on that. I can focus on that areas and I can work more. And let's say clinic and practice. So practice. That is the key. That is, that is going to give you so much confidence. The moment you go to the exam, you will not feel like you are under an exam or you are under pressure. You just will repeat the sequence as you as you become more and more confident. Even while you're sleeping, someone wakes you and asks to examine, you will be able to examine. That is the important thing, recognizing the sequence, not missing the steps. That is the key step, I will say, key thing. Without stress, under stress you should be able to reproduce that is very important. Of course, don't take stress on your mind, just relax on the day of examination, be confident. When you are going to exam, you should know that you should be 200% sure that I will not miss out the sequence. That is the most important step I will say. So, yes, Dr. Moses.
That's wonderful. That's the basic and core truth for the PACES examination. The people who practiced well, that we can see them during the exams and mock exams. The practice candidate will definitely stand out than a candidate who didn't do the proper practice for the PACES examination. They won't fumble and stumble. And typically they use a word called slick examination. They just go, they just know what to do. They do it and they'll sail away. That's fantastic. That's the truth. That you just reinforced it. Excellent. Fantastic. Thank you so much, Doctor. And one of the most important topic I wanted to discuss today is the cardiology station. Though outwardly many people, what I have seeing so many PACES examinations myself, like some people just go ahead and they just crack it and go. And also I found that's the station that can get absolutely tricky. Now they have something called station 3, where cardiology and neurology case both has to be seen together in a span of 20 minutes. So it can be a little stressful. And also I found the cardiology station is a station where people invent science, which is not there. And can you throw us some light and guide us like how to approach the station properly?
Yes, definitely. So yes, Moses, I agree. First of all, I would like to remind everyone that this is not an exam where examiners come to fail you, because that throws away all the stress from your side. Okay, so everyone wants to see you, how much you know the skill set, like your skill set is how good is your skill set. Okay, I'm sure you will know the marking pattern. So there is a separate column for patient welfare. There is a separate column for seeing the patient physical signs. There is a separate column for how complete you do the examination. So everything has its own component, own marking pattern. And there are two doctors who are going to assess you. It's not only one person. So any case which is kept in your exam in PACES is already standardized. Okay, the morning, the exam, before the exams, both the doctors, both the examiners will assess independently and they will come out with hard-end findings. Okay, these are the findings which are there. Both of us are convinced, and this is what we are going to examine from the candidates as well. It is not like it's a rare finding which they should pick up. No one keeps an exam like that, and PACES is not meant for that, not picking a rare diagnosis, rare syndrome. They'll be extremely happy even if you pick the subtle, normal, common things. Okay, so common things are what is expected in the exam. So one of my friends went to he had a BCC, that brief clinical consultation. He went examined systematically. He was very confident, demonstrating confidence. His knowledge was demonstrating. Finally, he couldn't come to the exact, precise, diagnosis. Of course, he gave a differential. The examiners were impressed. Examiners were thoroughly impressed. And then finally, they told the diagnosis is this to him. Generally, it doesn't happen in PACES like that. And no examiner will come for a reason just to fail and then they will be happy. Nobody will be happy. They just want to assess your skill set. Okay. So first thing is be calm. Be systematic. Two things are important. Keep your mind calm. Go in a systematic way. In cardiology, 1 + 1 is equal to 2. Undoubtedly, there cannot be any multiple diagnosis. For example, if a patient is coming and having cyanosis, you pick that he is maybe in a middle-aged man having cyanosis. You pick the cyanosis in hands. So immediate next step will be looking for clubbing. Clubbing you should demonstrate properly at eye level. Okay, and immediate differential diagnosis in the back of mind will be just mostly it will be an asymmetric syndrome, because that is very common, I will say, or a tetralogy of fellow. These two, just two differential diagnoses. A middle-aged man with cyanosis coming as an exam case should be having either Eisenmenger syndrome or tetralogy of Fallot, because other cyanotic diseases, of course, the patients, the prognosis, mortality, the overall survival will be very less. Okay, so this is like, when the moment I see cyanosis, I'll be ready for a diagnosis of probably an Eisenmenger syndrome or a tetralogy of Fallot. That's how I think. So that's what everyone should think, I will say. Of course, we'll be discussing subsequently what kind of findings we get and what diagnosis we'll think about like that in the subsequent podcast sessions. And today as well, we'll have in this session also we'll have a discussion about that. So don't worry. 1 plus 1 is equal to 2. That's all. Okay. Don't think about 1 plus 1 can be 3 or 4 like that. Don't worry. If you get these findings, the diagnosis is equal to this. That's all. And don't get distracted by rare findings or unusual findings which you are not seeing commonly. Common things are common. That holds good for PACES exam as well. And the common scenarios in cardiovascular system will be valvular heart diseases, which can be aortic stenosis or aortic regurgitation, mitral stenosis or mitral regurgitation, sometimes combined lesions, aortic stenosis with aortic regurgitation, mitral stenosis with mitral regurgitation. Sometimes patients may be a case of post-operative mitral valve replacement or aortic valve replacement. Sometimes, rarely, can be double valve replacement. And hypertrophic cardiomyopathy can come as a differential of aortic stenosis and can be kept as a separate case as well. And congenital heart disease, tetralogy of Fallot, I will put it down the list. I will put atrial septal defect or ventricular septal defect or a patent ductus arteriosus having Eisenmenger syndrome. These are the common scenarios which you will expect in cardiovascular system. So have these in the back of your mind. Just be relaxed. Okay, be systematic. I'm sure you will crack the diagnosis. I'm sure you will get full 20 out of 20.
Absolutely. That is the most important thing you have just told. Another important thing, like exactly, that cardiovascular system is 2 plus 2 equal to 4. Same like neurology, which we are going to discuss soon. Like that's also same thing. Like in neurology, the examiners will start marking you the moment you started examining, because all the signs are visible. You can actually elicit and show to the examiner, and that's an excellent thing. And next thing I wanted to discuss, Dr. Haynes, is just like, can you tell us like how exactly a candidate should approach the cardiology? Because we have now a lot of sources and a lot of people teaching online, a lot of internet sources. Now almost everybody is becoming like, coming and telling this is the sequence, that is the sequence. You as a cardiologist and you as a candidate who clear the PACES examination, and you can just put us a guideline and like, step by step how this station has to be approached in general.
Definitely. I'll be happy to help about that. Every station in PACES will have all these 3 components: assessing knowledge, assessing the skill set, and assessing the your attitude towards patients. As Dr. Moses was telling, see, my neurology station, the moment I started examining, the examiners were impressed. I could see from their faces. Okay. So I just to give an example before going to again with the cardiology examination steps. So what happened was I was given I was put into a room where a patient was lying down, and above it was written difficulty in walking. That's all. That's the caption on the station. It's a neurology station. So cardiovascular station went well. Examiners were happy, and then I went to neurology, the parallel neurology, and this is what. So the moment I saw that, I just told her. I introduced myself, greeted her, and then I used the hand rub. Then I told her, "Can you please walk for me?" She was happily coming and started walking. I was holding both my hands, one in front of the patient, another in the back of the patient, so that I will make her comfortable, safe. I'll make her feel safe, and I'll watch her whether there is any safely. I can watch her what is happening. The moment I saw that, I could find that it was a cerebellar case. That's it. So the keyword was written up, and I made her walk, and that's when I picked up. So this is how we are going to. This is very important. Like impressing you can definitely impress. If you are a safe doctor, they'll be extremely happy. Dr. Moses used to say often, you should be a safe doctor. You needn't be an expert doctor. You needn't be having expert skills. You just have to be a safe doctor for handling the patients. That's very important. So coming to sequence in cardiology examination, Number one, the first most important step is greeting the examiners. They should, as you greet, you should confidently greet them. Okay, they should see that yes, a candidate has come and full confidence, full energy like that. They should be happy. Yeah, greet the examiners. Then read the instruction carefully. Just read the instruction above the patient's bed carefully. Use the hand rub before, and the communication is very, very important. Okay, so just start the conversation with the patient. I'm Dr. So and so. I'm from the general clinic. Are you Mr. or Mrs.? So confirm the identity, and then you can tell that I would like to examine you. Is that okay? And of course, you should ask: is there any pain anywhere in the body? Because if there is any pain, you should avoid triggering that. That's very, very important. And position the patient at 45 degree. Expose the patient up to waist and cover. So exposing and covering both are important. Okay, you cannot just like that uncover the patient and start examining. It should be very, very sensitive. This is very, very sensitive. Okay, this is what very important. When a patient comes to you, you should show empathy. You should show respect. You should be respecting their feelings. So tell your identity. I am Mr. I am Dr. Haynes. Are you Mr. So and so? I would like to examine you. Is it okay? Is there any pain anywhere in the body? And position the patient initially only at 45 degree. Okay, remember, you cannot change the patient's position, like as you like. Okay, so keep it 45 degree. That is the optimal position for examination, and then expose the patient adequately and cover when not necessary. And ask for a lady attendant if there is a female patient. Of course, they will agree, and there will be a lady attendant for sure in majority, and you can go ahead with the examination. So this is the basics. Then inspect from a distance. Just from a distance will give you many information, like is there any oxygen cylinder or oxygen port, mask connecting, and connection with the mask can tell you that patient. So these are subtle clues you should take into mind. Is there any oxygen? Okay, maybe the patient is in heart failure. You will think, you will directly get an idea. And mostly it will be a calm room. So listen for metallic clicks. Sometimes clicks can be audible. And whether the patient is breathing comfortably, and what is the color of the patient. Everything you can look at a distance and get an idea. And then you have to look at the hands. So I'll ask the patient to, can you stretch your arms for me? Like that. So then I look at pallor. Of course, pallor, eye is the best place. Even hands can reveal you. And clubbing, cyanosis. So these are the three findings I'd like to look in the hands. Of course, tobacco staining can be there. But be focused on your system, which system you're examining and what fluid is going to give you. That kind of idea in the back of your mind should be there. And then you can, as you look at the hands, then you go for feeling the hands for warmth, any oscular knots or generations, any ecchymosis or tendon xanthoma. Remember, in MRCP, generally they will try to avoid a sick patient. Okay, generally patient will be a little on the stable side because sick patients may not cooperate for the exams. So that way they will try to balance it. Okay, so that you should be keeping in mind. Okay, it is difficult to find an infective endocarditis patient in a real life exams. Next, you go for the head to foot analysis. Yeah, any dysmorphic faces or xanthelasma, corneal arcus. Then eye, you can look for pallor and icterus. Then go for mouth. So look at the face. So I just for a short recall, I don't want to push you with so much information. First, greet the examiner. Go confidently and use the hand rub. Read the instruction carefully. Start communication with the patient. Okay. So I am so and so. Are you this? Is it okay to examine you? Like that you can go. And if then inspect from a distance. Is there any oxygen, metallic lakes, breathing comfortably or not, color, like that. Then you have to look at the hands for pallor or clubbing or cyanosis and feel the hands for warmth, oscular nodes, generations, fistula, or any tendon xanthoma. Then comes your head to foot. In that we'll predominantly focus on the face. Okay, foot we can take it at the last. Okay, so you can look at any dysmorphic faces, xanthelasma markers, like that. Then comes the most important step, examining the pulse. Okay. So while you're examining the pulse, make sure that you examine at least for 10 seconds. Be calm. So as you examine, you should be able to observe and retain what are the positive findings you get. So that way, pulse is very, very important. So you have to check the rate, as you know, and rhythm, whether regular or irregular like that, and volume of the pulse. And if there is collapsing pulse, then character of the pulse, and then radio-radial or radiofemoral delay. Of course, the radio-radial delay we will try to do, and radiofemoral. And remember, in NHS and in PACES, you are not supposed to examine on the clothes. You have to expose and do the examination. So I would say radiofemoral delay you can skip. At the end, you can tell that I would like to complete my examination to look for a radiofemoral delay like that. That's not a problem. So these are the sequences which you should follow. And finally, I am not able to. So of course, character you can check with the carotids. And collapsing pulse, you should follow a special. The exact thing we will be discussing subsequently. Collapsing pulse, how to examine. So that we'll discuss subsequently. So if I am not getting an idea about volume of the pulse, what can I do? That comes the role of blood pressure. So tell that I would like to examine the blood pressure. At this juncture, you can tell that I would like to examine the blood pressure. And one of our mentors told, don't ask the BP, tell the BP, like that you cannot ask the examiner. Okay, they are assessing you. You can tell that I would like to check the blood pressure of the patient. That's when they will pitch in with information. So pulse pressure, that is the difference between your systolic and diastolic blood pressure, will give an indirect idea of how is the volume. So normally the pulse pressure will be 30 to 60. So if it is less than 30, it is called as a small volume pulse. If it is more than 60, then it is the pulse pressure is more than 60, it is called a large volume pulse. I'm sure in aortic regurgitation you will get a large volume pulse. Okay, and so this difference, the moment you ask BP, you are ruling out aortic regurgitation, right? Agreed, Dr. Moses? So that will indirectly tell you, indirectly give an assessment. So so far I have examined the pulse. I am pretty sure what could be the diagnosis, any atrial fibrillation or not. The most important different diagnosis you should rule out or rule in is atrial fibrillation as you check the pulse rate and rhythm. Subsequently, volume, if you are very, very much doubtful after feeling the volume, I'm not very sure whether it is high volume or low volume. At the moment you get the BP, you will get an idea. And BP will indirectly give a clue whether there is any aortic regurgitation or not. Then comes your JVP examination and hepatojugular reflex after ensuring no pain in the abdomen. So you have to tell that I am going to look at neck pulses. Can you turn towards your left side? Okay, already the patient is on 45-degree angulation. So now you can go, after ensuring that there is no pain in abdomen, just have to press softly the right hypochondriac region and then look at how much elevation it's happening. Regarding JVP also, we'll be discussing subsequently in the podcast. So I'm not going into the details. Next comes the examination of the chest. So pulse we covered. After head examination, the faces, abnormal faces and all, we are going to chest examination. In that you have the inspection, palpation and auscultation, and percussion is not needed. So inspection, remember 3 things. Palpation, remember 4 things. Auscultation, remember the 5 areas of auscultation, plus or minus some extra areas. So that we'll see. So inspection, look at the apical impulse. It will be visible in most of the patients kept in the exams. However, if a patient is a female patient or a obese patient, may be difficult to find. That's fine. That is totally agreeable. And then precordial bulge, you have to go the foot end or look at perpendicularly, see how just have to at the eye level see how much bulge is there or not. And the precordial bulge is a marker of congenital heart disease. Okay, the cardiomegaly has happened even before the ossification is done. And look at scars, any scars like any previous chest drains or any scars in the midline sternotomy scar or submammary scar, which can give an indirect clue that some surgery is done. If there is midline sternotomy scar, you will think more in favor of a coronary artery bypass graft surgery. Whereas if there is a submammary scar, then you will think in terms of a valve replacement. So these are the indirect evidences which help you, as you have more and more information at the end of the examination, you will know this is the diagnosis or these are the differentials. That's how it goes. So then comes to palpation. So inspection, I told 3 things: apical impulse, precordial bulge and scars. Now comes to palpation. Palpation, you have apex beat, parasternal heave, palpable second order sound, and thrill. So these are the 4 findings. Inspection 3 findings, palpation 4 findings. Apex beat, parasternal heave, palpable second order sound, and thrill. So apex beat, we'll have to importantly check for the position. So make sure that you count the rib spaces. That is very important. Without counting, you will not be knowing which position you are telling. And try to find out what character it is. Heaving, thrusting, or tapping, okay, or hyperdynamic. Of course, thrusting and heaving are almost one and the same, so don't confuse. Just commit. It's tapping or normal, or it is hyperdynamic or heaving. Thrill, parasternal thrills. So palpable murmur is going to cause the thrill. And palpable second order sound, which can be a marker of pulmonary hypertension. And coming to auscultation, I told 5 areas of auscultation. So what are they? First, you go auscultate the mitral area. And if there is, you should, mitral, then tricuspid or the lower left sternal area, then the pulmonary area, and then the aortic area, then the second aortic area or the ABS area. So these are the 5 areas you should auscultate. That is mandatory things. If you have a murmur in the mitral area, you should auscultate the axilla. There is no doubt about it. And if you have a murmur in the aortic area, you should auscultate the carotids. So these are the gold standards. All right. So then what are you going to focus while auscultating? You have to focus on individual heart sounds, the S1, the first heart sound, the second heart sound. Is there any added sound like a click or ejection click or opening snap? And then the murmur. And then if you have a murmur in those areas, do this dynamic auscultation maneuver. Breath held in inspiration, breath held in expiration. So this is very important in the presence of a murmur. If there is no murmur, no need to do that. Dynamic auscultation may not help you. Okay. And if you have a mitral murmur, make sure to turn the patient to left side and then check for diastolic murmur, because that is how we are taught and that is how it is expected. If there is some diastolic murmur, it will be heard best in left lateral position. So you are supposed to turn the patient to left side, again turn back to the 45-degree angulation. So those are the steps you should not miss. After that, after doing all these things, after you auscultated everywhere, you can make the patient sit. So this is the first time I'm going to make a postural change for the patient. So first, the moment I entered, I made him comfortably lie down in 45-degree angulation. I exposed adequately. This is the moment I'm going to make him sit. Okay. And then you have to look for presacral edema and auscultate in the basal lung base for creps or any coarctation of aorta murmur. Then finally, at the end, look at the legs. You can look for any graft scars or pedal edema. So while sitting, what extra tip I'll give you is, if you are doubtful about whether JVP is elevated or not, you are not very sure, then make them sit and look at the JVP. Obviously don't look, you just have to look, and if you have doubt at the neck pulsations during your initial stages, now you can revise. If the JVP is still visible, JVP is visible during sitting posture, that means it is elevated. This is an indirect clue that JVP is elevated. And while palpation of your apex, if your apex beat is not palpable, what are you going to do? You can turn the patient to a left side. While palpating the fifth intercostal space, you can turn the patient to left side and see whether any impulse you are getting. And again turn back. Finally, at the end, after back examination, you are going to see the legs, and then finally that's the end of your examination. By now you should have in mind what are the positive findings, what I am looking at. So I would strongly suggest that you have to complete the examination before 5.5 minutes. Out of the 6 minutes, 5.5 minutes you should be able to thoroughly complete the examination, and rest 30 seconds you can assimilate what are the findings you got and what is in favor of your differential diagnosis. So before closing the examination, you should always tell thank you and cover the patient. So these are the attitude these are the things which are expected in a PACES examination. I'm sure I will have clarified a lot of things, Dr. Moses.
Fantastic. This is so elaborative, and even I was just listening, like kind of like all these things. It's like a revision for me. It's such a great explanation of cardiology system. Thank you so much. And obviously, many people, like like I was always used to tell, many people try to see so many unwanted things about JVP, like trying to assess the waveforms or comment on waveforms, which basically wouldn't be required in PACES, I reckon. Is it?
Exactly, exactly. I just want to know whether there is heart failure or not. That's all. Based on the JVP, I just want to hear the answer whether there is heart failure or not. You don't have to commit A wave, C waves, nothing. No, not at all needed.
Absolutely. As an examiner, you won't be needing all these things just to know whether it's a failure is there or not. Exactly.
Yes.
And one more important thing I wanted to ask you at the moment when it comes to examination is the collapsing pulse. See, I've seen a lot of people doing various techniques. One technique is like, wrap your arms around and then suddenly lifting up the hand. And other time, I've seen other physicians, especially these UK-based physicians, doing a distal cutoff. They keep another hand in the brachial area and then again lifting up the hand. And so many variants of it. Like, can you just throw some light on it, what it is exactly and how exactly to feel it? A lot of people fumble in that collapsing pulse examination.
All right, that is an important question. So, pulse examination, it carries significance, as I discussed earlier. You should be very clear in your mind, calm in your mind, and try to assimilate each and every point from that examination. So, maybe rate. Of course, rate can multiply by 6 until if there is irregularity that it should be commented, because finally at the examination, at the end of the examination, you'll be telling whether there is atrial fibrillation or not. So that is a very, very important thing. And coming to the collapsing pulse. So what is collapsing pulse? That idea has to be there before we examine the collapsing pulse, right? Normally you examine with 3 fingers, the radial pulse, your index, middle and ring finger. Compress the vessel against the head of the radius, and you will try to feel how it is. Generally, other pulse characters you will check in carotids, whereas this you will press against the head of the radius and assess. So, what are the other names of collapsing pulse? It is also called as water hammer. Water hammer is going to hit hard, and then pulse cylinder or Corrigan pulse. These are the other names for collapsing pulse, and this is found by Dr. Thomas Watson, who was an English physician. So he named after a Victorian type. It's basically a sealed glass tube with water in a vacuum. So the water will fall suddenly and hit the tube. So, and that hits like a water hammer. It's a hammer effect. So what it is nothing. It's nothing but a large volume pulse with rapid upstroke and rapid downstroke. That's all. So you will feel that the vessel is filling suddenly and completely emptying. Filling suddenly and completely emptying. That is your collapsing pulse. So how I'm going to examine? So I'll keep 3 fingers in the radial pulse as I examine normally, and I'll be ready to lift the hand. So I will want the patient that I'm going to support your arm and I'll be lifting you. Please leave it to me. Like that, you can tell the patient prayer so that the patient will not keep it stiff. And before doing all these things, ask the patient, is there any pain in your shoulder? Because that is one important thing you should not miss out. I'm sure Dr. Moses will agree, and Dr. Moses used to tell, you cannot make a patient wince in front of the exam. You cannot make it. That means it's a crime and you are gone. So it's very important to see the patient as you examine, see the patient's face, how they are feeling, are they comfortable? That is very, very important. So alert the patient that you are going to lift the arm suddenly. You have to support the arm and feel the pulse with your 3 fingers distally and suddenly raise it. As you raise it, you will have a sudden large thud on your finger, and it will be completely emptying. So rapid filling and rapid emptying. So of course, the rapid emptying could be contributed by the peripheral resistance, sudden fall in peripheral resistance because of the immense large cardiac output stimulating the baroreceptors. So it is basically a high systolic BP and low diastolic BP. That is the main reason for this collapsing pulse. So the most important thing is of course, telling the patient, giving prior information, and make sure that he's not becoming uncomfortable. I've checked multiple times. I am not able to find out What is the solution? So if you have a patient and you are examining, and at the end of your collapsing pulse examination, you are lifting suddenly and you are still not able to find it, whether there is a rapid thud and rapid fall, what are you going to do? So in that moment, I will tell you that please move to the next step. I would like to check the blood pressure. Like that, you can tell to the examiner if there is significantly large pulse pressure. Say for example, the BP was 140/30 or 140/40. Then it indirectly conveys that it's a large volume pulse which is happening and is going to collapse for sure. How will it double confirm it? So the the pulse pressure is wide. That means collapsing pulse should happen. Okay, that is number one. Number two, then you go for the auscultation. When you auscultate, if you auscultate in the herbs area, the second aortic area, or the third intercostal space, left side close to the sternum. So this examination is important for an aortic regurgitation patient. As you make the patient sit, keeping the stethoscope there, you'll make him lean forwards and look for increase in murmur intensity. So during that moment, you will double confirm. So first confirmation is by the blood pressure and double confirmation is by the aortic regurgitation murmur. That is your early diastolic murmur. So that's how we are going to examine. So it's a holistic thing. Collapsing pulse, even if you are not able to make out at the end of your collapsing pulse examination, it's okay. Just move on to the next step. Look at the blood pressure and auscultate the heart. I'm sure you will be able to pick it.
Absolutely, absolutely. That's a wonderful information. And thank you so much for opening our eyes in this, because a lot of people fumbled in collapsing pulse and a lot of people even invented science, whether what is a collapsing pulse and where exactly you get a third. And thank you for clearing up that for us. Thank you, Dr. Haynes. And that's a wonderful thing to know. And other one important thing I want to discuss is about the heart sounds, so many confusion, initially, especially for the candidates who are beginner, just fresh out of MBBS and fresh first year IMT candidates or fresh first year general medicine candidates. A lot of people have difficulty in knowing the heart sounds. What is an S1, S2, S3, S4, and especially a lot of people have confusion between a soft S1 and a loud S1, and where to tell a loud S1 and where not to tell it as a loud S1. And also when it comes to this valve replacement cases, many people who doesn't have a good basics on heart sounds, they fumble whether it's a mitral valve or it's an aortic valve, because nowadays we can't even kind of lateralize a finding based on the scar, because any scar can become for anything, and nowadays scars are very minimal also. So can you show and shed some light on heart sounds and what is the approach to that, please?
Yeah, definitely. I'll be happy to help. Regarding heart sounds, the most important thing is hearing normal heart sounds again and again. So practice is the key. I'll highlight the basics of heart sounds so that you can confidently interpret if whether it is loud or not and which sound you are hearing, like that. So what is the idea of first heart sound? You have a first heart sound or S1 and the second heart sound or S2. The third heart sound or S3 and fourth heart sound or S4. So out of which first and second heart sounds are very, very important. So what is the first heart sound due to? It is closure of your mitral and tricuspid valves. It will be having two components, but both will occur concurrently. The mitral and tricuspid leaflet closes almost similar. So we will not be able to hear any splits. And so the most important question will be, when will you call it as a loud first heart sound? Loud first heart sound. Because when we tell that, we will be implying that the patient may have a mitral stenosis. So that is the most important thing. So when will you commit it is if the first heart sound is louder than the second heart sound at the base of the heart. You know the apex of the heart and the base of the heart, right? The apex is going to be your fifth intercostal space, half an inch at or medial to the mid-clavicular line. That is your normal location of the apex pitch. So in that place, when you auscultate, if you feel that S1 and S2 are equal, doesn't matter. It has no implication. But when you hear the first heart sound, that is your closure of mitral and tricuspid valves, louder than the second heart sound at the base of the heart, that is at second intercostal space, that is when you will call as loud first heart sound. Most important point. So as you commit loud first heart sound, I am sure, as I told already, you will be thinking in back of your mind, this is probably a mitral stenosis case, all right? So to commit as a loud first start sound, mostly the S1, the apex will not be shifted. It will be at the same place. All right, can be shifted slightly laterally. Usually it will be like that. This is basically a correlate. So when will you record as loud first start sound? When it is louder than the second start sound at the base of the heart. But of course, the intensity of S1 has multiple factors, whether the valve is good, valve's position is okay, and then isovolumetric contraction. Because if a patient is having severe mitral regurgitation, the S1 will be completely soft. There will not be any closure at all. They will be closing and prolapsing into the left atrium, right? And myocardial contractility, PR interval, everything matters. But the key is when the S1 is louder than S2 at the base of the heart, that is at the second intercostal space, it is going to be loud S1. All right. So regarding the second heart sound, we know that it is going to be closure of your aortic and pulmonary valves, right? And it has two components. First, the aortic valve closes, then the pulmonary valve closes, right? So what are the things, differentials? So as you hear, what are you going to look at? You'll have to look at the split. That is very, very important. Because the split, if it is fixed, your diagnosis is easy. It is going to be an atrial septal defect, none other than atrial septal defect. Whereas, if the second heart sound is quiet, then you should think about calcific aortic stenosis. Can be a aortic regurgitation or a patient with heart failure with low cardiac output. If the second heart sound is louder, it can be due to systemic hypertension or pulmonary hypertension. So if the split widens in inspiration, normally what happens to the split? Normally the A2 will be followed by P2. That is normal. So during inspiration, it will be heard. The split will be nicely heard in everyone. And in expiration, it won't be heard properly. That is a normal physiological split. Whereas if the split is enhanced, so if it is heard both in inspiration and expiration, and if it increases in inspiration, okay, it's a wide physiological splitting happening, means it can be due to your pulmonary stenosis or pulmonary hypertension or right bundle branch block. So this pulmonary hypertension it should come down in the list, because the conventional teaching for pulmonary hypertension is going to be narrow split. Okay, so the highlighting points will be right bundle branch block and pulmonary stenosis. Fixed splitting we have discussed already. It is going to be in atrial septal defect. Whenever there is reverse splitting, just have two diagnoses in mind. One is your HCM and aortic stenosis. Reverse splitting happens in HCM and aortic stenosis, where the aortic valve takes time to close. All right. So this is with regards to first and second heart sounds. What about S3 and S4? So S3, getting an S3 and S4 in exams will be rare. In hypertrophic cardiomyopathy, you can hear S4, and S3 will be heard usually in heart failure. So S1 and S2, the phase between S1 and S2 will be the systolic phase, and S2 and S1 will be your diastolic phase. This S3 and S4 occurs in the diastolic phase. So it is also called as gallop sounds. So rapid ventricular filling in a failing cot can cause S3, rapid ventricular filling. Whereas S4 is usually heard in a forced atrial contraction against a non-compliant ventricle. So for S4 to happen, you should have sinus rhythm. The atrioventricular valve, that is your mitral or tricuspid valve, should be healthy, and there should be a non-compliant ventricle. So these are the prerequisites for S4. So S1 and S2 are very important, are the key in decision making. So S1 is your first heart sound. It is going to be a closure of atrioventricular valves, and your S2 is going to be a closure of pulmonary and aortic valves. Right, and S2, whenever you auscultate S2, look for the split. How is the split? Whether it is wide, narrow, like that. Pulmonary hypertension, the conventional teaching is narrow split, so leave it aside. Fixed split is going to be atrial septal defect, and wide physiological splitting can happen in pulmonary stenosis, right bundle branch block, and wide, reverse splitting can happen in aortic stenosis and HCM. So these are the common, heart sounds. So what are the extra sounds you should be able to pick up? So if you are thinking that it is a mitral stenosis case, then of course you should look for an opening snap, which happens after the S2. Okay, after the S2, you'll have an opening snap, and then followed by the mid-diastolic murmur. Similarly, in aortic stenosis patients, you can hear a ejection click. Usually when the aortic stenosis is due to a bicuspid aortic valve, congenitally abnormal bicuspid aortic valve. So generally this aortic stenosis occurs in the elderly. If it occurs in a younger patient, for example, a 40-year-old is sitting in front of you, having an ejection systolic murmur, be sure that you are not looking at HCM, hypertrophic cardiomyopathy. Second thing is, you should look for ejection click, because generally this bicuspid aortic valve will have an ejection click. Okay, so these are the basic things I would like to highlight about heart sounds.
That's
Is there
fantastic.
anything we need to add, Dr. Moses?
That's exactly what we needed. Let's give a good gist about the heart sounds overall. Like, and we can actually gonna go and discuss all these things as we discuss the individual valvular conditions in the upcoming weeks to months. And that gave a really good crisp information. Exactly what the candidates needed, both for the beginner level candidates and even for the advanced level candidates who are preparing for the basis examination. Fantastic, fantastic.
Yes.
Thank you so much. And the next important thing I wanted to ask you, couple of things before we wind up the session. One thing is this murmur, and there is a lot of controversies with the murmur. I've seen every basis examination after it gets over, there's always going to be some heated discussion like, was there a murmur? Yes or no? Is it a systolic or a diastolic? It's a mid systolic. So much of things, so much of confusion, and it varies from candidates to candidates. And sometimes I've seen certain examiners calibrating just like one murmur, that's fair enough. Same patients may be having a multiple murmurs leading to something else overall, and all the confusions. Can you just give us some gist about this murmurs?
Yes, definitely. So murmur is, for people who are not used to CVS, bit difficult actually, and some people will even find it difficult even after clearing their residency program, also internal medicine residency. So what the most important idea is, I would like to highlight on what all to look at a murmur and how we will look at a murmur. So what is a murmur? It's basically a turbulence inside the heart which is causing it. It can be due to a overflow of blood through a normal valve. That means I'm telling that it's maybe an anemia situation or thyrotoxicosis where there is a lot of blood flow occurring with normal valves, or a structurally abnormal heart, like for example aortic stenosis or mitral stenosis causing turbulence, and that is producing your murmur. I'm sure everyone will agree that the palpable equivalent of murmur is your thrill. So as you are going through the examination, in palpation only you will get an idea the patient is having a murmur or not. Of course, only the loudest murmurs will cause the thrill, okay, grade 4 or more. So you should be precisely auscultating as well. At the same time, palpation itself will give an idea whether the patient has murmur or not. That is very important. So don't miss out the murmur during palpation also, okay, because there you will commit palpable thrill, right? So as you approach the murmur, so when do you look for a murmur? Where do you look for a murmur? Of course, you have to look for the murmur in all the areas. So between the S1, so you should now, I'm sure everyone as they auscultate will focus on S1 and S2, the first and second heart sounds. So now is the time you should focus on the break between the S1 and S2 and the break between the S2 and S1. I mean to say that the pass, the silent area between the S1 and S2 and the silent area between the S2 and S1 should be focused. So the more and more you see, the more and more you hear, I'm sure you will be able to appreciate whether there is a murmur or not. The first question is whether there is a murmur or not. I'm sure you'll be able to answer. If there is a like there's some sound is coming, then of course that space, that silent space is filled with something, so there is a murmur. You can commit strongly that there is a murmur. Now comes the big question. What is a murmur? Is it systolic or diastolic? So as you come through this much steps of examination, at the end of palpation, you know that what kind of apex is there, right? So if it is a tapping apex, what murmur you will expect? I am sure I will expect a mid-diastolic murmur. So I'll be paying more attention to the diastolic phase, and I will make sure that I'll be making the patient to turn left side and auscultate. I want to be pretty sure that there is a diastolic murmur or not. So that's how my mind works, right? So as you go through the examination steps, you should have in back of mind what kind of murmur I'm going to expect in this patient. The patient is going to having a high volume pulse, collapsing pulse, BP is 140/30. What murmur I'm going to look at? I'm going to look at a diastolic murmur. I will make the patient sit and lean forwards and look at the ERBS area, that is the third intercostal space, left side close to the sternum, with the diaphragm of the stethoscope, to look at a diastolic murmur. So it should be programmed. As you examine, you should have in back of your mind what murmur I'm going to expect. There is a heaving apical impulse. Heaving apex beat is there. What murmur I'm going to expect? I'm going to expect a ejection systolic murmur of aortic stenosis. So I'll be focusing between the S1 and S2. Is there any murmur? Where it is heard properly, whether it is in the aortic area or mitral area, I'll be focusing on that, right? So as you see the murmur, as you hear a murmur, to confirm that it is systolic or diastolic, the most important step is palpating carotids, which I didn't mention in the examination steps. As you examine each and every area of the heart, mitral area, lower left sternal area, tricuspid, pulmonary, aortic, second aortic, you should have a finger in the neck palpating the carotids. So you should warn the patient, I am going to hear your heart. During that, I'll be having my finger over your neck. If there is any discomfort, please let me know. That's how your explanation to the patient, so that each and every auscultation finding, you will know whether it is systolic or diastolic. So whichever is correlating with the carotid pulse is going to be your systolic. Whichever is not correlating will be your diastolic. Agreed? So that's how it is going to be. So now then you will go to the page, quality, radiation, site, timing. So I remember with the mnemonic PQRST. Low pitch or high pitch, quality, rumbling, rough rumbling, harsh blowing, like that. Radiation, whether it is radiating to the axilla or to the carotids. And site where you hear the murmur. And then timing, whether it is systolic, diastolic. Based on that, you can come to a conclusion very easily. So everything is interconnected. Your vital sign is interconnected, your pulse is interconnected, BP is interconnected. Finally, at the end of your examination, I am sure you will be able to arrive at a diagnosis strongly. Say, for example, if a patient is having pansystolic murmur, my diagnosis is narrowed down. I would be thinking of mitral regurgitation, tricuspid regurgitation, or a ventricular septal defect. That's all. So mitral regurgitation murmur will be best heard at the apex, whereas tricuspid regurgitation will be best heard in the left parasternal border, close to the sternum. And ventricular septal defect, of course, it's left parasternal border, but usually at the third or fourth intercostal space. And mitral regurgitation murmur will increase the expiration. So all the left-sided murmurs, remember the word L-E-F-T. So left-sided murmurs increase with expiration. And right-sided murmurs, R-I-G-H-T, R-I. So right-sided murmurs will increase with inspiration. So your tricuspid murmur will increase in inspiration, mitral regurgitation murmur will increase in expiration. So, and if there is an ejection systolic murmur, my diagnosis will be, see, it is very, very rare or unlikely to have a pulmonary stenosis patient in your exam. It is where, usually pulmonary stenosis occurs in connection with other valves. Okay, it won't occur separately as a separate entity. So as soon as I hear the ejection systolic murmur, it's a very good quality murmur heard in the second aortic area. I mean, not the second aortic area, second intercostal space close to the right side of the sternum, which is connecting the carotids. My diagnosis is straightforward. It is going to be under aortic stenosis. Okay, if there is an ejection systolic murmur close to the sternum, which is connecting to the carotids, my diagnosis is very straightforward. It's going to be aortic stenosis. Whereas same kind of murmur is occurring, there's no connection to carotids, then I'll think in terms of hypertrophic cardiomyopathy. Whether there is hypertrophic cardiomyopathy, right? And when you have a diastolic murmur, if there is a mid-diastolic murmur, it is going to be a mitral stenosis. If there is early diastolic murmur, it can be aortic regurgitation. So we have covered almost all the valves. And remember, in prosthetic valves, the most important key thing, because prosthetic valves are more and more commonly kept in the exams. One of my friends attended an exam basis, and he was kept a case where there was a scar, midline scar, and P2 was loud. There is no valve clicks. What could be the diagnosis? There was a soft murmur in the pulmonary area. That's all. He told, okay, there is a murmur. This is the finding. These are the findings. And then he gave differentials. He told it probably had something to do with the mitral valve, and they have done a baby valve replacement. And then with that, pulmonary hypertension is there. Because of the pulmonary hypertension, there is a murmur and there is a scar also. Because if it is a prosthetic valve, metallic valve, you will clear the metallic click. If it is a bioprosthetic valve, it is very difficult to hear the bioprosthetic. Because bioprosthetic is nothing but your tissue valves. Your tissue valves means tissue valves won't produce abnormal noise. So for prosthetic valves, if it is a metallic valve, generally they keep metallic valve. The metallic valve, generally the most common valve to be replaced are mitral valve and aortic valve. So if you hear a metallic click, which is corresponding to the first heart sound, how will you make sure that it is first heart sound? You will auscultate the carotid. So whichever is coinciding with the carotid pulse, if the first heart sound has a metallic click, that means the patient will have a mitral valve replacement. Whereas if the second heart sound has a metallic click, then it is understood that the patient has got an aortic valve replacement. Very easy, right? So that's how you should have a differential in mind. As you auscultate, you try to, consolidate the findings, palpate, look at the scars. If there is scar, of course, there is some valve replacement. Most likely, valve replacement is possible. So that's how you have to correlate the findings. In the presence of Eisenmenger syndrome, so the moment you saw the patient looks blue and there is clumping cyanosis, you will have in the back of the mind that this patient can have Eisenmenger syndrome. So Eisenmenger syndrome patients can have pulmonary regurgitation, and that can cause early diastolic murmur. Because the pulmonary artery gets dilated, the valve will not be able to oppose each other, and that will leak. So that could be the reason for a early diastolic murmur in the pulmonary area. So this is how I will approach a murmur in a PACES case, and I will try to come to a conclusion. Hope that clarifies, Dr. Moses.
Absolutely. That's awesome and mind-blowing information on murmurs. It's completely refreshing, and you just divided everything in the right way, and information was absolute brainstorming. Thank you. Thank you so much. Thanks, Dan. And the next thing we are going to discuss is the concept of dynamic auscultation. Like recently, there was some HOCM case that came here in India in some centers. And some candidates actually did it, and some candidates were confused what to do. And can you just shed some light on what is a dynamic auscultation and what is the importance of it, and what are the conditions associated with that can actually warrant a dynamic auscultation in a cardiology station in PACES examining?
Sure. So dynamic auscultation, I will say, is incorporated in our examination in PACES, because dynamic auscultation is doing some maneuvers and making the murmurs differentiate each other, and we'll get extra information from them. So my common differentials for aortic stenosis will be an hypertrophic cardiomyopathy. So I'll be happy if a patient utters aortic stenosis or hypertrophic cardiomyopathy for an ejection systolic murmur. At the same time, to differentiate it, whether it is really an aortic stenosis or a hypertrophic cardiomyopathy, this dynamic auscultation really helps. So my suggestion will be, at each and every site, whenever you are hearing a murmur, make sure that you hear the murmur, you see that which phase of the respiration the murmur is prominent. As I discussed already, right-sided murmurs, all the right-sided murmurs and heart sounds increase in inspiration. There is only one exception, that is your pulmonary ejection click. Whereas all the left-sided murmurs and sounds will become louder during expiration. That's the norm. So respiration per se is a dynamic auscultation. Assessing the murmurs and respiration per se is a dynamic auscultation. Apart from that, what else we can ask the patients to do? Positional changes. So two things. First is a respiratory maneuver, which we are commonly employing in MRCP exam. And second is postural changes, sitting and leaning forwards, turning towards left side. So these are the things, which makes the murmur appears prominent, right? Apart from these changes, we can make the patient stand, squat, and we can ask them to do Valsalva maneuver. And we can ask them to do a hand grip exercise, Okay, so these are the things which can be employed bedside. However, no examiner or the patient will like to do that often. So what I will strongly say is go ahead with the respiratory maneuvers, and then go ahead with postural changes you want to make apart from standing and sitting. As I discussed already, no patient would like to stand, sit again and demonstrate the finding. So, and I'm sure no examiner will precisely want to know what is the diagnosis like that. Of course, they want to have a differential. They want to assess your knowledge, assess your attitude while you are examining the patient. So these are the important things I will suggest. And to precisely answer this other dynamic maneuvers, Valsalva maneuver is one. So what happens is, when you do Valsalva maneuver, straining phase of Valsalva maneuver, the amount of blood reaching the heart will become low. So whenever the cavity becomes narrow, the murmur will increase in HCM. So whenever the cavity size decreases, the HCM murmur will increase. That's the same thing happens when postural changes. This is the moment the patient stands, the blood flow to the heart will decrease. So the cavity size will decrease and the murmur of HCM will increase. And mitral valve prolapse is not often kept in exams. I don't want to discuss, and I don't want to, create a problem between mitral valve prolapse, HCM and all. But generally HCM you remember. And after doing isometric hand grip, if you ask them to clutch their hands, hand grip, if they do, the afterload increases. That's when the cavity size increases, and that decreases the murmur of HCM. Okay, so these are the classical points you can commit in exam. And I'm sure you should not miss the respiratory maneuver and normal postural changes which we tell the patient to do, like sitting and leaning forwards or turning left lateral for getting an idea about the murmurs. Hope
Absolutely.
that clarifies, Dr. Moses. Yeah.
Absolutely, that clarifies everything. And this is really great information about this, this dynamic auscultation manual, which is extremely important when it comes to MRCP basis is concerned. Nowadays, because of the cases that are coming out like that, like two centers had spoken cases back to back.
Okay.
Just clarified it.
All
That's
right.
really great. And, uh,
Understood.
and ultimately, I want to ask one more important topic is the JVP. Of course, like you said, like you just need to know as an examiner, you just need to know like whether the JVP is raised or not. But many times candidates get confused between the carotid pulsation and JVP. That too when people are at the rush. Can you shed some light on that or just a few points about JVP examination?
Definitely, I'll be happy. So, regarding JVP, don't get scared. Look at the neck calmly. Make the patient relax. So, so some important things. So, of course, the patient is sitting at 45 degree. As I discussed already, you are going to start the patient examining at 45 degree angulation only. So, you know that the patient's right side is the best place where you can look at the JVP. So, the patient should be relaxed and turning slightly to the left, not fully to the left, and it makes the muscle start and you may not be able to get the findings at all. So, relax, slightly turn to the left. Just pay attention. Is there any visible waveforms? That is the first question I will have in my mind is there any visible waveforms? If it is there, I'm sure as you palpate the pulse, you will know what is the heart rate or the pulse rate, right? So based on that, with each and every pulse rate, like of course you will know whether there is tachycardia or bradycardia. Two waveforms nicely prominent in the neck. I'm sure in exam we are not going to take a scale and measure the height, right? So if it is there, nicely prominent two waveforms and up to the angle of mandible, I will say. That's all. That's enough. I will say it is JVP is elevated. I don't want to push more towards the concept or the exact methodology because see, whichever findings is prominent, they will have in the calibration. As I discussed already, two examiners will calibrate the patient before they give to you for examining. So both of them should be having a strong acceptance that the JVP is elevated. Then only they will get into calibration. And the moment you see if there are two dancing waveforms in the neck with each and every pulse, each and every every heart rate, that means it is going to be an elevated JVP for sure. Whenever you are missing that, take the opportunity to look at it when the patient sits up. You are making them to sit and examine the back at all. So that time you can have a look again and see if there is if it is there or not. So on sitting, the JVP should disappear. Okay. If it is prominent in sitting as well, it is going to be elevated JVP for sure, no doubt about it. And JVP is better seen than felt, whereas carotids will be felt only, it will be better felt than seen. So the moment you see there are pulses, visible pulsations, two pulsations per, two visible dancing things, dancing waves while you palpate the pulse, of course it is going to be JVP, none other than JVP. And of course, it is going to be lateral and it can vary with respiration. You can ask them to take a deep breath, and if you have doubt, you can do that as well. And finally, you can do a hepatojugular reflex. Generally, you just have to press the hypochondrium, and you can tell them that I'm going to press the abdomen. If it hurts you, please let me know like that, and then you can start doing that. Generally, it transiently rises and it decreases. If it is persistently rise for more than 10 seconds, we take it as abnormal. Can happen in heart failure. So I don't want to go into the details of JVP because you just have to tell whether the JVP is elevated or not, and it's just a visible inspection finding. It's not a palpation finding. Remember that. So I'm sure it will be visible, obvious. And if the patient has pedal edema as well, at the end, if you are finding pedal edema as well, there is high chances that there can be elevated JVP. That's it. That's the clue.
Wow, such a great information and like a lot of tips about JVP. Even like we had a lot of confusion when we were practicing for for patient's examination, because many a times we don't get a bedding like that where we can keep the patient on the appropriate degree and then exactly see the JVP or see the waveforms, and
Yes.
that clears a lot of doubts on JVP. Absolutely. And finally, before we wrap up, and one important doubt which most candidates raised is apex split. And especially this comes, and it comes into trouble when they're going to get a female patient. It's very difficult to make them properly undress and cover them and do the apex. And also in obese patients, it's very difficult. It's getting very difficult to palpate an apex. So can you shed few points on apex before we find it?
Definitely, definitely. The apex beat is felt with the pulp of the finger, not with the tip of the finger. Remember this. This is the most important point. So as you examine more and more apex beats, I'm sure you will know. So it is nothing but, of course, there will be some cases where you will not be able to get a proper apex beat at all. Some obese patients or female patients do tend come to our examination as subjects. So the procedure is same as before. Like the patient should be lying in 45-degree angulation, and you will try to localize generally below the nipple. Go with the pulp of your finger and feel for some thrust or hit on your finger's pulp. That's what you're going to expect. Suppose you can ask for a female patient, you can definitely ask permission. I'll be pressing on your left side of your chest. If it hurts you, please let me know and go ahead and do it. Still after that you are not getting it, you can definitely ask them to turn to your left side. I would like to check. Like that you can tell. The most important thing is most of the cases you'll be able to get it. Rarely you will not be able to get it. Then you would rely on other findings for confirming your diagnosis. I'm sure examiners do agree with that. If there is no clear-cut pulse apex beat, it's not a problem. However, they will be expecting you to feel nicely and make the patient turn to left side and confirm that there is no apex beat at all before you commit that there is no apex beat. So, and the next important thing is the moment you are telling that there is apex beat and it is in this intercostal space, this much medial, lateral and all, they will definitely expect you to count the spaces appropriately before telling that it is in this space or not. So for counting, use 2 fingers of your left hand. Right hand will be in the apex, and keeping it there, just count from above, from the sternal angle. Just lateral to the sternal angle will be your second intercostal space, and you just have to take it gradually from there and try to find out. With regards to apex beat, if it's a lateral displacement, it is going to be an RV enlargement. If it is down and out, it is going to be an LV enlargement. You can think about those differentials, and if the apex is at normal position, you think about mitral stenosis or aortic stenosis, because of course mitral stenosis, there will be tapping apex, not much of deviation will be there, and aortic stenosis also, the initial stages it will be concentric LVH, not much of changes will be there, but the apex it will be heaving in nature. So what is normal apex beat? Generally it will be at 5th intercostal space at or medial to the mid-clavicular line, and it will be lasting for a few moments, less than 1/3 of the systole generally. And in case of a heaving apical impulse, how will you tell that it is heaving? The timing will be increased, the amplitude will be increased, means the pressure will be increased, and the duration will be generally be more than 2/3 of the systole. That's what we conventionally say. So it lifts your finger and sustains and then drops. That's how your heaving apex beat looks like. And you should always think about aortic stenosis, coarctation of aorta, or hypertension in that. And if there is hyperdynamic apical impulse, it will rise and drop transiently. More than one intercostal space will be involved. That is the most important key. If you are getting an apex beat, more than one intercostal space, and usually it will be down and out, usually in a hyperdynamic apex. So such situations, you will think that it is probably a volume overload situation or volume regurgitation lesion. Valve regurgitation lesion is there, like an aortic regurgitation, mitral regurgitation. Of course, there is no hard and fast rules. However, I'm sure with practice and with this technique, you'll be able to pick the apex.
Fantastic information. Thank you so much. That shed a lot of things about apex beat. Like a lot of people get panic if they don't find an apex beat, and they end up spending so much of time just finding out the apex or trying to find out some character, whether it's tapping or heaving, and they're losing the money on that. Like the money of the cardiology is entirely on the auscultation, and actually, yes, opened our eyes on that. Thank you so much. And finally, before we wrap up, can you just what are the take-home points for a candidate who's preparing for PACES from your end? What you exactly want to tell?
Sure. I'd be happy to share that. So far we have seen about the examination sequence, and I will put my weight on examination sequence, because the moment you are thorough with examination sequence, you will be spontaneously doing it. Without, at spinal level, you'll be doing the examination sequence and your mind will be receptive to the findings. If you are not thorough with the sequence, you will be spending more energy, more of your mental work to, focus on whether you are doing the sequence correctly or not, and you will be maybe missing out the important findings. So doing the physical science is a systematic sequential examination that carries a most important point, I will say, for getting the findings right. So sequence should be thorough. And one of my friends used to tell, see, even if you don't get a subject, just keep a pillow in front of you and examine. Just do the sequence, correctly do the sequence. So that's how you practice, keep on practicing, and that's going to help you immensely in your real life exam. And second is patient comfort and communication with the patient. So you should tell, thank you. Each and every step you can tell, thank you for that, I appreciate that. So that's very important, thanking the patient. Of course, the patient will go up for you and the examiners will be very happy. You are keeping a patient comfortable. You're communicating with the patient, I'm going to check your pulse. I'm going to lift your hand. If it hurts, please tell me. If is there any pain in the shoulder? Is there any pain anywhere in your body? These are the important things you should communicate with the patient. And as you examine at each and every point, each and every checkpoint, like pulse, you should have a differential. As after you hear the BP, you should have a differential. You cannot command the examination to give the BP. You can tell that I would like to check the blood pressure. They will definitely come out with blood pressure answers. So that will give you immense clue as you go ahead with the examination. Before reaching the auscultation only, you will be able to have a differential diagnosis in mind just by looking at the clubbing, cyanosis, and apex beat. So thrill, heave. So much information you get. So this information can be assimilated and used for precisely looking for what murmur and which area at the auscultation. So don't spend time, another thing is don't repeat the sequences. Like the moment you complete, again I'm going to examine from the beginning, I have doubt in this, that nobody likes actually, and even the patient doesn't like, the examiner also doesn't like. So don't repeat the sequence which you have done already. Make sure at each and every step, make sure that you have done it and then move. At the same time, don't waste any more time on one particular area, because that is not going to give you adequate information. And JVP, I'm told already that if there is doubt, please make the patient sit. While sitting, I'm sure you'll be making the patient sitting and examining the back and all. That time you'll be examining. And apex, if not felt in supine, make them turn lateral and check. And JVP, don't worry, just see two waveforms are there or not. If it is not there, okay, it is not there. And if you have doubt, you can do a hepatojugular reflex and confirm the finding as well. And so BP and volume of pulse are interrelated. Apex beat and murmurs are interrelated. So everything, so that kind of mindset, that integrity and the integration thing has to come in your mind, and that will come with practice. So just keep practicing. And finally, importantly, cover the patient and say thanks. And just try to finish the examination between 5.5, that means 5.5 minutes, and just press 30 seconds. You try to, summarize what are the findings, positive findings, just from the beginning till the end. What are the positive findings I have in my mind, so that the moment the examiner starts the question, you'll be able to give a good answer. And I will say that friend or study partner is a must-have for PACEs to crack it and coming out with the colors. So I'm sure study partner is very, very important, and be having a very helping you, and of course both of you learn from each other, and it will be a very great help. So one of my friends did a PACEs exam, CVS. She at the end, she didn't even check the pedal edema. But she passed with flying colors, So because the examiners were impressed with the way she examined, and she has come out with the proper differential diagnosis, and they were happy. Just for the sake of pedal edema, they didn't harm her. They were happy. At the end, they were happy. So they told, the examiners themselves asked, what did you miss in the exam? Because she recognized at the end that she didn't check for pedal edema. Then she told, I missed the pedal edema. She came out with flying colors. So no examiners come as a person to fail a candidate. They will want to assess your skills, and I'm sure it is very important. Your attitude, your communication, your knowledge, everything matters. Your skills, everything matters in examination. Not only one particular domain is being assessed. So I wish you all the best.
Thank you so much, and that shed a lot of light on this, and that's a scintillating information. And 1 hour, we had such a brainstorming time with you. It's such a pleasure to have you here, and I hope this would have definitely benefited all the candidates who are just started preparing, and as well as the candidates who are approaching their exams. And we are going to have 4 to 5 more sessions with Dr. Haynes with us on cardiology. We are going to discuss about the valvular heart disease, valve replacement cases, congenital heart disease, and even hypertrophic obstructive cardiomyopathy. And all those things we are going to discuss. We are going to have many more exciting sessions with Dr. Haynes. And thank you so much, everyone, for listening. And especially thank you so much, Dr. Haynes, for coming all the way here in spite of your busy schedule and dedicating this time for us. Thank you so much. We are such a pleasure for us and such a honor for us. Thank you. Thank you so much.
My pleasure, Dr. Moses. Thank you. Thanks for this opportunity. Thank you very much.
Thank you.
Pleasure teaching. Thanks.